All right, so today we're going to talk about neck trauma. Welcome. How many of you read about neck trauma? Be honest. Okay, this is going to be interesting.
Like read this week about it, or?
Yeah, at least read about it, at least in the past 3 or 4 months. Because if you read about 3 years ago, it doesn't really count. So if you're an intern and now you're a chief, that doesn't count. So, all right. So instead of kind of doing the traditional, I'm going to tell you all the things you need to know, I'm going to give you questions. You're going to tell me the things I think you need to know. How about that? All right. So again, this is going to be neck trauma. So keep your mind on that when we talk about these things. Let's see here. All right. So if somebody gets stabbed in the neck, just bleeding, you go to the operating room. And you kind of see the patient as a 3 on a DCS. Go to the operating room, and you see that the common carotid is transected. What do you want to do?
They completed their stroke?
You don't know, right? Yeah. So what do you want to do? So it's completely transected. They're a GCS of 3. And the patient is hypotensive. Make it easy. Do what?
Make sure they're flat, back bleeding.
Okay.
Figure out how.
Say that it's back bleeding.
Okay, figure out how far the defect is.
Let's say it's a knife wound, right? So you have a centimeter.
I mean, you should be able to bring it together if it's less than a centimeter.
Could, yeah. Okay, let's say it's 2 centimeters.
2 centimeters, reverse that.
Okay, somebody's hypotensive.
Or tie it off. We'll be done with it.
Okay. So what's the outcomes of tying it off? What are the stroke rates?
20%.
100%?
20.
Okay, so it's roughly around 20 to 30%. But you don't know this person had a stroke, all right? You're assuming because they had GCS of 3, but you don't know what the problem is. So what else can you do?
Shunt.
There you go, yeah, shunt. Right? So some textbooks will say you can tie off the carotid artery, you can. It just realize that you're going to have high stroke rates. So the in between is shunt them. Get them out of there, find out what's going on, you'll come back and put in a graft if you need to. Okay? So that's pretty easy for that one. Okay, so a patient is in a motor vehicle crash. Come in, they're kind of awake, GCS 12. Complains of C-spine tenderness, has weaknesses in his left upper extremity. What do you want to do? How do you want to work this up? You have weakness in the left upper extremity. And it's kind of, again, in the context of what's going on in the neck.
The CT of the C-spine?
So you get a CT, right? And so say the CT of the C-spine doesn't show a fracture or anything like that.
We also get a CTA of the neck?
Okay, so why do you want to get a CTA of the neck?
Possible dissection or flap?
Okay, but what else is there? So your head CT is negative. Your CT C-spine is, which is called negative. But what would make you do a CTA? Why would you do it?
Neuro deficit not accounted for by the CT.
Okay, so unexplained neurologic deficit. Okay, where the patient was a GCS of 6. CT, the CT of the head was negative, nothing really that was there. CT of the C-spine,
What was the
nothing really there.
Can't get a reliable neurologic exam. So.
You can't, right? So what would you want to do? Why would you do a CTA on that patient? Or would you do a CTA on that patient? GCS 6.
Probably would just because of the mechanism. I mean, you got a rapid acceleration.
Well, you don't know, right? CT of the neck is negative. So, what do you think? Anybody else? I know some of you should know this because I did send out things recently. Castille, yeah, calling you out. So the WTA guidelines, the Western Trauma, talks about blunt carotid injury or blunt cerebrovascular injury. And so an unexplained GCS less than 8 is indication for a CTA. So again, if you get a CT and does not look convincing on the head or the C-spine, think about CTA. Because again, it could have a significant injury. If you miss it, it's a big deal. But we'll talk about more about that later on this week. Okay, so how about Patton? What are the zones of the neck in the anterior triangle?
You got on 1, 2, and 3. 1, clavicle, sternum notch, right.
Up to the what?
Up to the
Cricoid?
cricoid, up to the base of the jaw, basically.
Angle of the mandible?
Angle mandible up to the base of the skull, 3, so 1, 2, and 3.
That's what, okay, so why do we care about zones?
It helps you determine what structure underneath the zone. There's actually.
It's not really the structures, because they're all the same, really.
Management?
So management, what does that mean?
Well, like zone 3 is really hard to get to surgically, so anything in that zone, you're gonna try to probably go more endovascular.
Okay, so would you do an endovascular procedure on a zone 2?
Depends on what it is.
Okay,
If they're stable versus unstable, it's the same.
okay.
Unstable, you would probably take it to the OR.
It gives you an algorithm. so-
Sure does. So what is that algorithm?
It depends on what zone, hard signs, soft signs.
Okay, so it's not really a zone necessarily, but signs. Okay, so what are some hard signs?
Active arterial.
Yeah, so it's easier, right? Active
Neurologic deficit.
Neurologic, not necessarily.
Expanding
Expanding hematoma, okay.
Hoarseness.
But that's not a hard sign. Hoarseness is not a hard sign. So what else? What happens if you got stabbed in the neck and you got the trachea?
Stridor.
That's kind of a softer sign.
Crocuses.
Maybe. What's more is something else. They're talking to you, they're saying something, and all of a sudden you look at the neck wound and you're like, oh, bubbling, right? Yeah. So again, you're gonna have some bubbling. So the soft signs are gonna be hoarseness, necessarily stridor, dysphagia, hemoptysis. Those are gonna be the softer signs. So it's gonna make you think, okay, something's going on, and then depending on the patient's status, what you're gonna do. Either go directly to the operating room, or you're gonna do adjunctive studies. So what are some things you can do when the patient is hemodynamically stable, it's kind of talking to you, but you got this thing, you're like, I think something's going on. So how do you want to work that out?
CTA.
Okay, so if you're concerned about the vascular injury, right?
Swallow
So
study.
I'm sorry.
I said a swallow study.
Okay. Talk about that a little bit.
Just trying to
Say a
rule,
swallow study.
to rule out an esophageal injury.
Yeah, what are you using?
Uh,
Say swallow study. What med students don't know what that is.
Thendarium.
You need Thendarium? Is that gonna be the first thing you use?
Gastrographic.
Okay, so water soluble. All right. Okay, so water soluble, and what else? So fiber optic, flexible. So you can do the bronch, trachea. Okay, what else? Okay, so again, softoscopy. So how good are those?
Good.
When you say good, what do you mean?
Almost 100% sensitive.
For what? Which ones? Tell me.
Esophageal injury with the esophagoscopy and contrast wall.
Okay, good. All right. What else? What about CT for an injury?
CT
How good is that?
scan with oral contrast for the esophagus is pretty good at detecting injury or leak.
Yeah, but it's going to be hard though. A lot of times to do oral, right? Because you have to do it in a special way because it's going to be right. As soon as they drink it, they got to take it. So, I mean, but just the CT itself is actually pretty good because it's going to give you an idea of what the trajectory of things are. And it's going to be next to structures that you're going to be concerned with, and then kind of proceed with your other workup. Okay, so what about just physical exam by itself? Say for a vascular injury. So somebody comes in, they get stabbed, you kind of look at it going, physical exam, is it good or not good?
As
I'm sorry?
I said not as good.
As good as what?
The imaging and the.
Are you sure?
I would think so. I mean,
Okay, you think so or is it only you read?
I think so.
Okay, so you'd be wrong. So physical exam for vascular injury is actually pretty good, always according to the data. So if you come in, so they take two different routes. One had this physical exam versus getting imaging. Physical exam group did just as well as doing a CT for a vascular injury. So yeah, physical exam is pretty important. Okay, so we got that. What else we got here? Okay, so you got a patient that's 1 week out from a negative exploration of the zone 2 injury from a stab wound. Now you notice there's some erythema and there's swelling, there's some cloudy fluid drainage from that wound. What are we worried about?
Esophageal injury.
Okay. Or what else? Say it was the left side, zone 1, zone 2.
Allothoracic or like
Okay. So again, so what does that mean? It's not really chylothorax because it's not really
the
endothorax.
duct is reached, it's crossed over and is now entering into the.
So what duct?
Right.
Okay. So you guys understand that, right? The trajectory of the thoracic duct. So sometimes you're gonna see that, it's gonna be injured. You're not gonna necessarily see it at the time of your operation, it's very thin, it's kind of small. You're gonna get obscured by blood and other things. So be aware that you can potentially get injured. So what do you wanna do with it? Say it's injured. You go in, you do exploration the second time, what do you wanna do with it? Because you don't know, right? So it's easy as cardiac will come out, you don't know if it's esophageal, a missed injury, or from esophagus or thoracic duct. So you're gonna explore it. So if you see a thoracic duct that's injured, you can't really repair it, really, usually. But yeah, I was gonna lie to you. But what if it's an esophageal injury? Now it's you see it, and oh wow, it's there.
Repair and drain.
Repair it. What do you mean repair it? A what? Two-layer repair after a week out? Is that gonna be good? So medical students, what's the problem with the esophagus compared to other alimentary canal structures when it comes to fixing them, repairing them? What's different?
Does it have a cirrhosis?
It's got what? Not necessarily. That's not the way. Yes, but not the reason. I mean, most of the esophagus is smooth muscle. What's different? Okay, but yes. So there's also rosa to it. So it's not the layers aren't very strong, especially the muscle layers aren't. So it has a propensity to break down. So if you have an injury that's out even just 24 to 48 hours, you have an increased risk of having things break down and become a big problem. So if you're a week out, probably not going to be a good idea to do a primary repair. You can try to get away with it, but you're not high. Just understand you're not high bleed rate. So what else are you going to do? So you go in, you see it, you read it, you want to put it together, drain it. What else? It goes in, so you go in, it's pretty big, nasty. You're like, I can't really repair this. What's what?
I said a feeding tube.
Well, yeah, that's part of it.
Exclude.
A lot of times you have to exclude. And so when you exclude, what does that mean?
Staple off the.
I'm sorry?
I said staple off the esophagus and like create a spit fistula.
Okay. Sure. Let things kind of calm down, go back at a later date and fix things. All right. What else do you need to do if you're doing that? If you're doing a primary repair of the esophagus and say it's a lateral kind of posterior, you want to do your primary repair, this is the first operation, you go in from the stab wound, it's there, fix it, what else you got to do? Okay, with what and why?
Intercostal muscle, depending on where you're at, strap muscle, whatever you can flap over.
Pretty much. But why? Anybody else besides Rudd?
Prevent fistula formation.
Fistula to what? Okay. So again, the esophagus is intimately associated with the trachea. So you can repair, especially if there's an endodontous serosa, you're going to put some kind of buttressing in between. Depending on, like I said, the location, you can use a bunch of different things. So what are some things? We said trap muscles, intercostals, what else? Sure. What else? But again, this is in the neck, so you're limited. The esophagus in general, we can use a lot of different things. Pericardium, pericardial fats, momentum, such different things depending on the location. All right. Guy comes in, gunshot wound to the neck. He's breathing right now, he's okay. You see this hematoma that kind of is there, not necessarily getting bigger, but there. He's in it's a zone 2, kind of a high zone 2. And what do you want to do? So it's not really expanding, it's there. You're concerned. But again, zone 2, kind of high-ish. It's kind of more of a read my mind type of a thing.
Physical exam.
So yes. So the physical exam shows the hematoma. So what do you want to do? Hematoma, okay, right? So you're like, okay, there's something there, it's kind of a softer sign. So something's going on. What's that?
I'm gonna say get CPA because of water.
Okay. So what do you want to do maybe prior to that? Okay, so why? What's that? Speak up, what did I do? Does not sound off.
You could expand
It could, right? So you could lose the airway. So the big thing in that one is to make sure you understand, focus on the airway, ABCs. Make sure that's there, because all of a sudden, you're like, okay, it's a hematoma in the neck, oh, it's looking okay right now. As soon as you lay that person down in the CT scan, they will die. And you'll be like, well, what happened? Well, it's because I lost their airway. And a lot of times they're going to be sitting up for a reason, because they're maintaining the airway all that. So it may not be expanding at that particular point, but things happen. So understand, airway is going to be always the important part. All right. What else do we got? Okay, so let's say zone 2, stab wound, stable hematoma. You get your CTA and you see like what's called a type 2 carotid injury. All right, so it's about, say it's 50%. That's included. What do you want to do? Zone 2.
Needs intervention.
Now this one, yes, intervention, absolutely. So what would we want to do? Now this is one of those that the textbooks tell you one thing, well, certain textbooks will tell you one thing, other textbooks will tell you something different.
Interesting.
So,
Some will say surgery, some will say.
exactly. All right, so for the score, they'll tell you that any kind of zone 2, they say do an operation. Even if it is, something that's pretty obvious, as opposed to being, unless they're exsanguinating, it's the operation is there. So somebody who's stable, who does have a vascular injury, endovascular, it does have a role for zone 2s. So the score will tell you differently, but in the trauma books, they'll tell you that there is a role for that. Again, it all depends on what you have in your institution and what your interventional people can do for you rather quickly, but you don't want to wait around for something to happen. So you can do it fast, you can do interventional stuff. What else?
What's the role for like a young patient that's like 20 years old, has this injury, and you're putting a stent up there in their carotid?
You don't know. You don't know the outcomes over time. We don't even know the outcomes over time for grafts, because you don't do a lot of grafts on 20-year-olds. You know from older people, they last a certain period of time, but if you're 20 and all of a sudden you're 45 now, is that graft done or what? So, from the observations, you don't follow people up that long, so you never know what happens to them over time. Same with stents. Short term, they do great. What happens over time, it's hard to say. They get lost. And it's kind of a newer technology, so we don't know the answer to that. So there's a potential, and that's always the kind of the argument is that we don't know what happens over the long term. But short term, they seem to do save people big operations, so it's hard to say. But again, it depends what you have in your toolbox. Okay, so 25-year-old driving pretty fast on the freeway, smashes a car, smashes his neck on the steering wheel, has stridor, kind of cyanotic, having difficulty breathing, obviously. Comes to the true, and you're looking at him going, this is a problem. What are you going to do? What do you want to do? Intubate, okay, so you're trying to get in there, I can't do it.
Like an awake.
Okay, you can try to do an awake, a bronch, but would you want to do that? He wants to do the awake bronch.
Okay. You're saying like he's imminently failing right now, I don't want to wait, I want to crack him, but.
Okay, so stridor, cyanotic, not breathing. All right, so, okay, right. So, medical students, can you walk us through a brachydothyroidotomy?
Unfortunately, no vertical incisions.
Make incisions, take back the scalpel, open it
Or
up.
anything, really.
Anything, get to,
Pretty much. Alright, so why do that as opposed to a tracheostomy?
You want to do tracheostomy in the OR?
Yeah, but you can do a tracheostomy anywhere. What's that? What's quicker? Okay, why is that? You can do it probably anywhere. You can do a thyroid. You can do a tracheostomy anywhere. Doesn't matter if it's an OR or not. You just want to get an airway. But if you're in the trauma bay, why a brachydothyroidotomy as opposed to a tracheostomy? They're all tracheal rings. Cartilage is all there. It just doesn't make a difference. They're all pretty easy to get through memory wise. The why. So Beatrice, why? Yeah, so thyroid gland gets in the way. So you don't have to, there's nothing in the way, basically. So as you get down, it's the most prominent point in the neck, most superficial, easy to get to. Then you go back and invert it. All right, so again, airway, always remember your ABCs. Somebody comes in, they don't have a good airway, make one. Ideally, you like to do a translaryngeal, but if you can't, then put a hole in the neck. All right, what else we got? Okay, this is a sort of an interesting one. A 32-year-old male struck in the right neck by fragment from an industrial explosion. Pretty interesting. Patient is seen outside hospital with a 1 centimeter wound to the right lateral neck. Hemoglobin was stable and neurovascularly is intact. CT is consistent with no vascular injury, but error is noted in multiple fascial planes in the bilateral neck. What do you want to do? Oh, wait, what do you want to do?
ABCs.
Sure.
Has the airway.
That's it, yep.
We need to evaluate the esophagus to see if he has esophageal injury.
Okay.
Also needs a bronchoscopy as well, or some type of laryngoscopy.
Sure.
Evaluate the-
What if you just said, you know what? I'm going to watch it. Could you do that? Your CT scan's broken.
You can watch
Your
it.
fiber optic bronchoscopy, the pulmonary fellow is using it.
You can watch it.
Can you?
You can.
You sure?
Yeah.
Positive?
Positive.
Okay. So you can, yeah, absolutely. So what would make you think something's wrong? All of a sudden you admit them, this is where you actually physically have to go see the patient multiple times. So what are some things that you might go, oh, we need to do something?
Crepitus is getting worse.
Okay, I'm going to say the worst thing, sure.
Goes into more, requires more oxygen.
Well, hopefully not more oxygen. It's not going to have a pulmonary problem. And if it's that big of a hole, you'd see it quicker. If you're losing that much of your tidal volume going up the neck, you would see it much, much sooner. So you shouldn't be requiring oxygen. Somebody else said something. We already talked about it.
Optosis.
Hemoptysis could be something you're concerned with. What else? Ronnie, I know you're on there talking about something. What's up? What do you think?
I said hemoptysis.
Okay, hemoptysis, what else?
You start getting like a cellulitis.
That's going to be later, though. Cellulitis is going to show up for probably a couple days. If there was an injury and did nothing. So what else? So hemoptysis, yeah. What else? We already talked about it. Was that?
Although that would have been present initially, but that
Yes,
bubbling.
that's a harder sign.
Yeah.
But this is something you hit, and all of a sudden 5 hours later.
More horse.
Okay. So hoarseness, dysphonia, dysphagia, odonophagia. All those little things that they teach in medical school. So you'd see that. So if all of a sudden they're not be able to, the hoarseness or the way they speak is different. I mean, you'd be, okay, there's something that's going on, and make you do other things. But again, it's, this just kind of tells you that you don't have to do everything at once. That depending on what you have available, you can observe these people. But if you're going to do that, you have to make sure that you're actually doing your physical exam on them. You can't just say, yeah, we're going to do it, put him on the floor, and then 24 hours later, go see him and he's in there dead. But again, physical exam is really important. All right. We're going to kind of talk about that a little bit. Somebody, so Fran gets in a fight. She stabs somebody in the neck. And it's a tracheal injury. So in the operation, you see it's there. It's an injury. How do you want to fix it?
Vicryl sutures.
With what?
Vicryl?
Sure. Does that be Vicryl?
Have to be.
So why do you want to use Vicryl?
I just wanted to use an absorbable suture.
Sure. That's perfect. But what else?
Stitches are on the outside.
Of
Trachea.
Yeah, I don't think it really matters, to be honest. Because both, technically, on the inside, the trachea is outside.
And buttress something across it as well.
What's that?
I said and buttress something across your repair as well?
Well, not anteriorly.
No,
You
okay.
don't care about that, because there's nothing really there, so it's just the posterior portion of it, yes. But again, some of the textbooks say for a tracheal injury to do a tracheostomy at the time of the injury. So you don't have to do that. You can actually do a primary repair. You get translaryngeal radiation, do the primary repair. For a gunshot wound, depending on how much is lost, is what determines whether or not you need to do anything different. But if you do a primary repair, do a primary repair. So one of the things that one of my trainers in fellowship, they would always do the tracheostomy on people, even with a small injury. It's like, why are we doing that? You can actually do a primary repair. What else? Sometimes, okay, again, for the repair portion, the score will tell you to use non-absorbable sutures. You don't need to do that. You can use absorbable sutures.
What's the size that you go up to before you switch over to doing trach versus primary?
What do you mean size?
Of the injury? 2 centimeters, 3 centimeters?
It depends on what you can be able to bring together without a lot of tension. So a lot of times if it's more than a centimeter, depending on the patient, how body habit is, you're probably going to have to do the tracheostomy, come back a different day. Depending on the patient's clinical status, is kind of really determines what you're going to do. But a lot of times, especially for a stab wound, you should be able to primary repair those. Now we talk about high energy, with like a gunshot wound or an explosion or something like that, that's going to be a whole different story.
This was on, not this year, last year, there was an actual question on staff wounds.
Yeah.
With the airway.
So most, like I said, vast majority of stab wounds, because again, it's a clean cut, it's low energy, you should be able to bring that together primarily. Granted that you do have the airway secured. That's always going to be the biggest thing on any kind of exam, is what's the airway doing. Because again, you can have a complete transection of your trachea. And that's going to determine what you're going to do, is whether or not you can be able to get the airway or not. So if you get the airway secured, then you can have time, and you can actually potentially do a primary repair if you have enough without any kind of tension. That's a trickier phenomenon you have to worry about. What else is there? So what are some neurologic structures in the neck that you're going to be worried about, especially in the anterior triangle? So recurrent laryngeal is one of them. What else?
Phrenic?
What's there? So Vegas is going to be one of them. Where's the Vegas located?
Cottage too.
Okay. What else?
Phrenic?
Phrenic nerve. Right? Don't forget about the phrenic nerve. It's going to be kind of deep, but
Anterior to the anterior.
it's going to get you. So all of a sudden, this is where that O2 might be coming into play. If somebody's not intubated, but they have a real deep neck wound, and all of a sudden their phrenic is out, you have some problems with your pulmonary status. That'd be highly unlikely to get both of them out and still be alive, because that would necessitate a big, gigantic wound that would cut off both of them. But weird things have happened. To understand that the nerve structures. What else is in the neck that's not as consequential?
Long thoracic.
Long thoracic, okay, that's way back,
It's
but
posterior to the middle scale.
that's way back,
It's in
but
that.
sure. Okay, that's yeah, technically. We high up. What's that? The muscle fringe, okay. I guess technically, it's super high on the base of the skull. What's the ansa cervicalis? I don't even know if they really have consequence if you cut it off. So I mean, it's an active question. It's always
Get
one of those
corners.
things I can talk about, but you can burn it. What else do we got? So really just understand the different zones of the neck. The score will say for zone 1s, you're going to do a lot more in terms of endovascular stuff, just because again, a lot of times you're going to have to get into the chest. So, Patrick, what are some incisions to gain access to the vascular structures of the neck? Okay. Or any structure to the neck, how about that? So what you're saying is, yeah, so down on the border of the SEM, we award the SEM, which exposure to most of the carotid. And then you can do what else with that incision? Say you get in, you open that up and go, wow, the carotid injury is kind of lower than you thought.
We're doing sternotomy.
Now you have to get into the chest. So extend it to the mediastinum. What else can you do? So you have a low zone 1, patient's actually exsanguinating, you gotta get in there fast. What are you gonna do? What can you do? What are some other incisions? What kind of thoracotomy? It'd be tough because you're not going to get into the neck. It's hard to get into the neck with thoracotomy. And I guess you can do 2 incisions, but why do 2 incisions when you do like 1? What does that mean? No one does anymore, but why? What does that mean?
Second intercostal space, take it across, like mediastinum and then over and
Yeah,
basically articulate your
pretty
clavicle.
much. We don't really do that anymore because
It sounds
highly
cool.
morbid, and you don't really need to. Like I said, you have your neck section among your sternocleidoid, and you do a median sternotomy. So I don't know what to try to get at. Remember, thoracotomy and sternotomy are 2 different things. So the sternotomy is going to get you to pretty much all day access to things. So understand what that is, and you can do it pretty quickly, and that's going to be something that's going to be in your armamentarium. What about a zone 3? How do you access those? It's awful. Textbooks will tell you you can do it, but it's super difficult to do. I've never seen it happen. Usually they die before you can actually even get to it.
What about those like, yeah, the like proximal left subclavian stuff? Like, I don't know. That's what we were just saying. It's like, you know, they say the books say like you can do a thoracotomy, but it just seems like that'd be difficult to look up versus like
It is.
opening the door. This, I mean,
Depends on the patient's body habitus. Again, that's what's going to help you decide. But again, you can get access to this. You can get through just through a clavicular incision if you're trying to get the proximal portion. If you're getting proximal, just do a median sternotomy. Easiest incision to make, and plus you have everything there. So try to get to the distal portion. That's where it gets a little bit trickier. You can technically do it through a thoracotomy. If somebody's big, it's going to be hard to get there. Depending where the injury is. But a lot of times proximal should be pretty straightforward. The guys at LA just take the clavicle out. Just make an incision, just get around and pull it up. It's there. Everything sits right in front of you, so you don't need to do anything. The clavicle, you don't even need to replace. And you can leave it out, and then they'll still have the complete function of the extremity. So, but yeah, so some of the old textbooks say for that you do the open book one, but you don't do that anymore for that reason. All right, we got a few minutes. Trying to think what else they will be talking about. The posterior triangle was really not a whole lot there, other than some nervous structures, but there's really not much of an algorithm for that. What else? Any questions? Anything you're confused on? Anything you've read that I've said that's different? Since nobody read anything, it shouldn't be a problem. Okay.